This is on behalf of my co-investigators from Academic Medical Center in Amsterdam and Boston Scientific engineers in the development of an acute and chronic performance of communicating leadless anti-tachycardia pacemaker and subcutaneous implantable cardioverter defibrillator that is basically looking at combining an LCP with an S-ICD in order to produce ATP mechanism in addition to pacing. So the rationale behind this is that ICD therapy has many complications, not just in the short term, but over a long period of time. And when you continue to add leads, and I don't think it's any mystery why this abstract is inclusive in this session, is because you've seen a lot of the mechanisms to try to deal with chronic leads and multiple leads and things of this nature. So what we're trying to do is simplify the system. The main possibility to decrease the number of reoperations in the short period of time that a patient has this device in, or these devices modularly, and specifically try to decrease the surface area that leads to endocarditis that has such a high mortality rate at 1 year. So we've introduced the S-ICD for many years, and this is increasing in linear implant time. We're almost at 25,000 implants worldwide, and the complication-free rate remains quite stable over the long period of time. And this is from the pooled data, and this even carries forward even further with the 3-year data presented by Dr. Boersma of the Effortless Registry at HRS. So the application of the S-ICD is limited, however, due to the lack of pacing, and the capability for anti-tachycardia pacing seems to be an adoption issue, and people obviously have biases towards one or the other. But the consequence of trying to minimize the amount of hardware and simplify the system and decrease the installation for patients who are at risk for ATP is obviously enticing to just about anybody in this room who deals with ventricular tachyarrhythmias. So combining the implant in a remote sense is really a step forward in the modularity of device therapy and the iterative process of managing patients with prescriptions that are actually designed to treat that patient based on their presentation and not give an all-type device to all patients who don't necessarily need that, but at the same time give a lot of confidence to implanters to select, say, an S-ICD because they have a consequent patient who might have a ventricular tachycardia that needs an ATP module. So when we look at this, the next step is to really create a method that looks at 3 specific objectives. One is the LCP implantation itself and the functionality of such a device in animals. The device-to-device communication that's affiliated with this particular device that's set up from a research standpoint to actually communicate with an S-ICD, and then make sure that the S-ICD, when communicating, doesn't inhibit therapy or identifies appropriate therapy to deliver ATP. And then the therapy itself, look at ATP, S-ICD rhythm discrimination, and post-shock LCP function. Here are the systems, and also inclusive in this is a new programmer that you see in the left corner there, which is a tablet-like system that actually has a module to link into as well at the bedside, but can be carried in a much lighter sense to the usual Zoom programmer. So the delivery system prototype isn't much different than what you all had experience with LCPs thus far, with both Nanostim and with Micra, but the concept here is a little bit different, and there are some proprietary things that I won't get into. The telescoping sheath is a little bit longer, and the housing a little bit longer than what you're used to with current systems. And the leadless pacemaker system is not much different. The only difference is that it now can provide ATP. So it doesn't just treat bradyarrhythmias, but it also can treat tachyarrhythmias when it is notified to do such by the mothership, the S-ICD that's across the left ventricular apex, or the right ventricular apex in dextrocardia. And so the emblem PACE is a standard S-ICD lead with a prototype-based emblem that has the basic ASIC that is already in place in emblems that are being implanted today. So This type of a system would be backwards compatible with the LCP. That is, so any emblem that you're presenting the patient with today might be able to do this once approved, and it's just a software change. It's unidirectional, so and this is the first iteration of this particular combination of devices, but it's unidirectional in a conductive communication method. So there's inductive methods such as you see with EBR. This is a conductive method of communication, and a specific communication protocol had to be created because there are other ambient RF mechanisms in a lab, and you can actually see it deliver ATP if you don't do something that's a little bit like dot dash dot. So we get back to Morse code here. Specifically, when you look at, okay, good, it's playing. So you can see that this is the delivery of the LCP, and the first thing we did was an RV angiogram, and now we're introducing a 21 French introducer. There's a delivery catheter with the LCP housed in it. The telescoping sheath then it goes across in the animal. There's a little bit more of a right angle than you would see necessarily in the human model. We do another little Vino or RV gram right there, and then we deploy the device. It's still tethered at this point. The housing is coming off, and then you can see it's not too different. It's like a combination a little bit of the micro and the nano stem. This is just a different LEO type view to see that you're housed in an appropriate way. And you have to think of this because the communication has to have a dot dot dash to the A to the B, so it goes in sequence, and it sends two of these communications across in order to maintain some degree of solidity and confidence in communication. Then you put in an S-ICD successfully, and it's a little different in an animal model, but essentially you're sandwiching the LCP between the coil and the can. So we studied 3 different animal models. We had ovine, swine, and canine. The majority of the chronic data is in swine. The LCP was positioned majority in the apex or the low septal area or the high apex, and then the outflow tract in one patient just for functional assessment. And then you can see that the pacing thresholds, the impedances, and the R waves are all relatively stable. And this is acute. This is at the time of implantation. And if we look at the long-term progress of the animals, specifically canines, at 30 days, you can see that there's a nice stable run of thresholds and impedances in the animals to date. This is the interesting part of this particular abstract, which is the LCP shows a successful communication in 3 postures. So not just an acute supine posture communication where everything is hunky-dory and the animals in anesthesia, but that we then take them in the chronic sense and we get threshold data. Now this is important because if you are going up to 7 volts in order to communicate, you're going to start getting some skeletal muscle. In humans, animals, I'm not sure exactly what their sensia is, but in humans, we probably hear a lot about that. If they're going to get an ATP, it might send a little bit of a, maybe they'd stop the DT before they actually got the communication. But nonetheless, the thresholds on the LCP are well within reason at 2 volts, and they're stable over time in 3 postures. Because of this, the high success rate for device-to-device communication was seen in 309 attempts, 306 were successful. And this is really in the worst case scenario that we might see compared to a human model because the angle of the device is really almost parallel to the electrodes that you're communicating from. And so the consequence here is to angle things a little bit differently. And these are studies that are ongoing for angulation so that we can give you some guidance when you're implanting these on exactly how they should be sort of the most effective and safe way of communicating. So specifically, we had a high ATP therapy success rate as well, 99%. So obviously, if it communicates, it's going to deliver ATP. And so the device is highly motivated to deliver this sequence of beats at 81% of the tachycardia cycle, much like you would program ATP today on a transvenous lead system. So the mean number of ATPs per animal was 8, and again, the success rate was really based on the communication success rate. This just is demonstrating the functionality of the device. You see the communication right there, and then a change in morphology with the ATP delivered. And right now we're just mimicking VT with pacing in the left ventricle, as you see in the animal model, X-ray to the right. And once again, we're just going to go through a full series just so you get a full understanding of what's happening. And the communication is quite stout, and you can actually see capture on a high level. There's no dysfunction in the sensing consequent to the communication. So the device is still sensing and still delivering automatically in a series that you might see if you program on this series of ATP. And then just to be complete, we wanted to do a shock to make sure that communication then occurred accurately after a shock and that the devices were impervious to this. And so that's what you saw here at the end, was a counter shock to the animal through the S-ICD to determine it. And this is just stop pacing. So this was a mimicked case of what we would naturally see in somebody. So more importantly, the adequate S-ICD rhythm discrimination during LCP pacing is very distinct, and you can see that even with pacing, the device can handle the paced rhythm transitioning from a sinus rhythm, and you don't get oversensing at all through the device, which is very important, obviously, as you're distinguishing between two devices that have this functionality. And then furthermore, in the typical sense, when we had dual devices and we were putting them in, and this is another, going back to the future, as it were, where you basically are looking at high output device pacing and ventricular fibrillation, sensing, and counter therapy not being inhibited by the device or by the pacing. And then unaltered post-shock LCP performance acutely. So in the patients that are in the animals that we did shock, you can see that the baseline numbers post-shock remain the same, including impedance and threshold, which I think is a new data set for this particular type of pacing. So these are numbers shock 2 to 3, and there were no dislocations or device resets of the ASIC consequent to the shocks. So in conclusion, LCP implantation delivered adequate VVI functionality, high implant success rate, device-to-device communication at a very high rate of success at 99%. The therapy was very good and did not alter the function of either device and module. And so adequate sensing during and adequate post-shock function of the LCP and the S-ICD, and there were no dislodgements or problems from shocking the heart. So really, just to get to the meat of this issue, this is really the first foray of modular prescriptive therapy that I think is the future of the device. And you can see the S-ICD is a very powerful platform for this. So we're looking at expanding this and understanding better the histology and acute and chronic implants. And then suboptimal device-to-device orientation in animal models, we're going to be doing a lot of mathematical assessment of angles so that we can get a very stout communicative process, maybe at a lower output than 2 volts. And then you can see modular therapy extending to an artificial intelligence type basis where you actually have, say, a cardiomems or a monitor of pressure inside the pulmonary artery that's measuring your hemodynamics and then delivering therapy at a time that it's necessary, just like we would at the bedside. And these types of communications and the ASICs involved have to be bidirectional moving forward. And that's one thing that I think we've learned from this particular endeavor as well.